check it whether it is visible. Is looking, it is looking. My view. Good afternoon, one and all. I request all of you to rise for the invocation.
धन्वन्तरी स भगवानमृतत्वदाता यो वैद्यकस्य गुरुरादिरनादिकालात् यो हार्तदेगमन आत्मसुखावहस्य नैरोग्यतस्य निदरां च नृणां हितस्य तस्यारणास्पदमहर्षिवरस्य शिष्य ये त्रेवयं प्रमुदिताननुभाग्यवन्तः देन प्रतीबितचरं सुचिरात् शुभायुः वेदस्य दीपामिह तत्पुरदोतरामः येन प्रभां वयमिहस्य विदद्य दिक्षु ज्योत्स्नां रुजातिशमनी प्रभवेम दातुम् व्यादिव्यकात हृदयाय इमानवाय देयं द्वितं भुवि कलापि च न किलैषः देयं द्वितं भुवि कलापि च न किलैषः देयं द्वितं भुवि कलापि च न किलैषः.
Please take your seats. Now I request Head of the Department of Plastic Surgery, JIPMER, Professor Friji, to welcome Chief Guest of the and the Speaker of the program, Dr. N. Jitendan, by bouquet. Professor of Plastic Surgery and our former Head of the Department, Dr. Devi Prasad Mahapatra, also please welcome by bouquet. These are greetings from JIPMER, sir, from Ashram. Now I request Dr. Mahapatra and also Dr. Friji to welcome once again by shawl. Photo, please. Mahapatra, Friji. Let us formally inaugurate the today's program. And I request Dr. Firiji, Dr. Mahapatra, Dr. Jitendran, and other faculty and participant who are available physically to lamp the light. Madam, you also join. Right time you have come. Be part of the inauguration program. Dr. Anjali. Please clap. Ishaq, help sir. Help Dr. Firiji. Help. Okay. Head of the Department of Plastic Surgery, Dr. Firiji, Dr. Mahapatra, Dr. Jitendran, and physically present consultants, residents, and those who are present online. I welcome you all for today's next JIPMER lecture series, which we have been doing regularly for this program today. This program is being telecasted across the world, as JIPMER is the regional resource center for telemedicine, and it is being telecasted to UK, USA, BIMSTEC country means Bhutan, Thailand, Myanmar, Nepal, Bangladesh, Sri Lanka, and also those countries like Morocco, with which we have signed MOU, and also those nodal officers who are coordinating and showing at their end this program to their participants. So I welcome you once again for this program. And this is the overview of the program. This is how we will go about. Of course, lower limb reconstruction is close to all the plastic surgeon to their heart, because there is no day or there is no part of their life when an occasion will come that they will face this challenging problem. And when the challenge is more challenging because of the complexity of the problem, then definitely you need to overcome that challenges. And that is how Dr. Jitendran has chosen this topic, that how to overcome those challenges which are there while reconstructing the complex lower limb defects or otherwise. It's my pleasure to introduce the speaker of the day, Dr. Jitendran did his master's in orthopedics from GSVM Medical College, Kanpur, and he did his MCH plastic surgery from University of Delhi, Safdarjung Hospital, and further did his DNB. He's a qualified teacher, and he has been mentoring and guiding the resident and the students. His professional experience is very vast, right from his after passing out from MCH, that he did his registrarship in Ganga Hospital, Coimbatore, and then further worked in SMRI Hospital, Dehradun, and then Global Hospital, Hyderabad, and Sparsh Hospital in Bangalore. At present, he is a senior plastic surgeon working in the Bangalore, including Apollo Clinic. Yes, he has done many courses and attended various workshops, especially those workshops which are close to his heart, like microvascular surgery, breast courses, and that too from Taiwan, and also various other courses and workshop, and he himself as a faculty participated in those workshops. As an active senior plastic surgeon, he has been regularly attending various conferences, both national as well as international. Actively, he has been presenting papers in the conferences and also the publications. He has extracurricular activities. I know every plastic surgeon would like to have a photography. So that is the part of our training and the course, but also chess, table tennis, carom, and cricket. Now, if you see his scope, in this you can see both the reconstructive as well as aesthetic. He is into it, and he is very well known in various groups like 10 PAPS, ISSH group, and other aesthetic groups. We know him very well, but for the knowledge of the residents and those who are not aware, it was my duty, and I'm very happy that he is with us. Welcome, sir, once again. And as I said, the topic is very important to all senior plastic surgeon, budding plastic surgeons, and of course, long case resident also. So definitely this topic is, we immediately accepted that there is a senior faculty who would like to speak on this. So sir, over to you. I request you to come here and start your talk.
Thank you. Presentation. Yes, ma'am. Yeah, okay. Good afternoon. So today we'll be talking about complex lower limb trauma and how to overcome the challenges which are associated with complex lower limb trauma. So lower limb trauma is very common and it is seen in all the emergencies. And lower limb trauma is very common. We see it in all the emergencies. Every time we come across any injury where the limb requires to be reconstructed. There are a lot of problems in the reconstruction. There's a lot of soft tissue loss. There's a lot of bone loss. There's associated vascular injury. Then there is contamination. And this requires multimodal means cooperation for getting a good outcome in such patients. A plastic surgeon is required because he is well versed with all the soft tissue. An orthopedic surgeon is required so that he is able to manage the bony deformities or the bony fractures associated with it. A physiotherapist is required to get the patient back to his activities. A psychologist to deal with the depression and his social problems. Okay, an occupational therapist to help him get on with his life after recovery. A prosthetist sometimes is required so that a process, if it is required for the lower limb, it can be given. So what are the basic principles? This is the first basic and the only principle which is followed for all the lower limb trauma. That is, whenever you get a patient with a complex lower limb trauma, you do the following things. You do a good debridement. This debridement has to be done by the senior most faculty of the department. It should not be left to the juniors, because debridement is one thing which has to be done and you get a good chance in the first attempt. And you are able to assess the injury. First is you are able to assess the injury. Then you are able to clean the wound properly. Then you are able to formulate a plan when you are doing a debridement. So it's essential that you do the debridement yourself. The second thing which is important is once you have done the debridement, then you do a skeletal stabilization. Skeletal stabilization can be done by either an external fixator or by plating or screws. Okay. Once you have done this, then you assess the vascularity. Vascularity, if it is not good, then you go ahead with vascular reconstruction. So after skeletal stabilization, you will go ahead with vascular reconstruction. You restore the circulation of the limb. Now comes to the next topic of coverage of the bone. The coverage is important so that you cover the bone. If the bone remains exposed, then you can lose the bone. So you require to give a good coverage early on. Then all the vital structures, if your vascular structures are exposed, they require a vascular cover. Nerves are exposed, they also require a vascular cover. So once you have given a good vascular cover, then you can expect that the wound should heal uneventfully. Once the wound has healed, then you go ahead with your bony reconstruction. If there is a bone gap, then you require to do a bony reconstruction. If there's a muscle and tendon gap, then you require to do a secondary reconstruction for reconstructing the muscle or tendon function. So this approach is basically described as an orthoplastic approach, where both surgeons combine together and try to give the best possible result for the patient. So how do we define a complex defect? A complex defect means it is involving more than one component. One is skin and soft tissue, muscle and tendons, bone, nerves and blood vessels. Sometimes the bone is not involved, only the soft tissue is involved. Then also it requires a lot of coverage. So that is important. So how do we decide whether to salvage or not? Supposing we get a patient in the emergency, we have to decide whether we should be able to salvage it or not. The most important thing is the general condition of the patient. Whether the patient is having any lot of comorbidities, whether he's got life-threatening comorbidities, whether he has got, whether they are able to resuscitate the patient or not. Then we have to decide what is the urgency of the means intervention which is required. If the circulation is not there, in the absence of shock, then we should think that there's a vascular injury, and the reconstruction requires there's an urgency of reconstruction. Okay, but if the patient doesn't have circulation and the limb is already dead, then you can't go ahead and reconstruct the limb. Okay, so rigor mortis is one thing which if it present in a limb, you will not be able to revascularize the limb. So that's an absolute contraindication for revascularization. So if you are doing a delayed vascular reconstruction in the presence of rigor mortis, your patient can die, and you can land with serious complications. So it's very essential that you intervene whenever you have a vascular injury. You have to intervene before rigor mortis comes up, or there's a collateral circulation which is present, which is able to hold on to the limb till the time you are able to revascularize. Then practicality. We are working in private setup, so affordability is one big issue when we come across any patient with a major injury, because any major injury will require a lot of financial burden on the patient unless the patient is adequately insured. Okay. Then second is motivation. Some patients are not willing to undergo multi-mode reconstruction. They are not willing to wait. For those people, multi-mode reconstruction is not a viable option. Okay. Then mental status. If the patient is not mentally resilient to undergo multiple stages of reconstruction, then it's better to avoid such a reconstruction. Okay. And you should. Okay. So again, coming on to the same thing only, that risk assessment is very important. You should assess the risk of reconstruction. If you are going to reconstruct a patient, you should do it safe, with the safety of life. So life should take precedence over the limb. If there are life-threatening issues which are there for the patient, it is better not to reconstruct the limb. Okay. Then the technicality, I already told: circulation, time of delay, affordability, and strong motivation. These are the four things which are very, very important. Circulation should be good, or you should be able to re-establish a good circulation. Then affordability in a private setup, not in a government setup, and strong motivation. Patient should be strongly motivated that I want to save my limb. There are a lot of patients who say that no, I want to get back quickly. I can't undergo any major reconstruction. Then we don't offer them such a thing. Okay. Then at the end of the thing, we should think that what is the end point of reconstruction? If at the end of a long and drawn out reconstruction, if we are able to achieve a limb which is not very useful for the patient, or the patient is not going to be happy with the end result, then we should not undergo or take up such a reconstruction. So it's essential that you visualize what is the end point of the reconstruction, whether the end point is going to be good enough for the patient or not. Okay. So then logistics. Patient is from a very far off place. He cannot come back to you. Then you should be able to hand over the patient to the other reconstructive team after doing the initial management, so that they can take it forward, and they should be equally competent enough to doing it. Okay. So there are multiple charts which are available which help make a decision, but these are not ones which are going to tell you about the finances or the motivation. All these tell about the technicality of the injury and assessment of the injury. Technical feasibility is one aspect of reconstruction, another is practicality. Okay. So assessment is very important. Any patient who comes to your casualty with a limb injury, first thing to note down is whether the circulation is intact or not. If circulation is not intact, then the time is ticking and you are racing against time. But if the circulation is intact, you can take your time to assess the patient and do things better. Okay. So there are multiple things which are there, clinical this thing. Okay. We'll go through some practical examples of such an injury. Okay. How it comes to us and how we go ahead with it. Okay. In this, can we have the screen up, upper screen down?
Just hide that
toolbar. Toolbar. Yeah. This one.
Yes.
That's fine. Yeah. So this is a 60-year-old gentleman who was referred to us. He came to us around 7 hours after an injury. But when he came to us, there was no circulation in the limb. He has a circumferential wound across the entire side. You can see just 1 second. Okay. 1 second. Okay. So if you see that there's a skin loss here, this whole skin is degloved here. Here again, there's the lateral aspect. There's a medial aspect which is degloved. There's a posterior aspect which is degloved, and there's the anterior aspect. So all throughout the side, there's a degloving of this thing, and there's a comminuted fracture beneath it. Okay. So the problems are, you've got circumferential soft tissue loss. There's an absent distal pulses. There's a comminuted fracture. He's also got a associated head injury and anemia. So again, the delayed presentation, absent distal pulses. The same thing which I have again told it here. Okay. So there's a CT angio which shows the absence of circulation at this level. So we went ahead and first skeletally it was stabilized, and then the antitibial vessels were anastomosed with a vein graft. So with that, the limb survived. The posterior vessels, we could not find the proximal end of the posterior vessels. So once the limb has survived, we went ahead and identified the proximal end of the posterior artery above, and we put an LD flap on it. LD flap, we split it into two. One was the anterior aspect, one was the medial aspect. So it was from the posterior aspect, it diverged into two and covered the entire this thing. So with that external fixator, if you can see, there are two things which are here. These are to keep the external fixator higher up, not making the leg dependent on. It is to keep the limb elevated all the time, because the flap is circumferential. So with that, we see that the wound has healed. This around 6 months after that, he was walking with a walker. Then he started walking with a stick. If you see, he's able to walk with a stick. We didn't have to do anything further after this. The wounds and the bones healed automatically. And with the external fixator itself, the entire bone has united. And then you can see there's a deformity. This deformity is because initially the fixation was not great. So there was some amount of bone displacement. That's why they have this thing, plus a small amount of flap. But you can see him around 2 years follow-up, he's able to walk around. Okay. So it has healed without infection. he's able to bear the this thing means his whole weight of the body, and he's able to do his normal activities. He's a villager. Okay. So, and he could not afford any further surgeries. One surgery and means we could do it. There's another case. There's a young patient, 16-year-old gentleman, road traffic accident. He was actually traveling in a two-wheeler and collided with a four-wheeler. Okay. If you see, there's an extensive injury to the leg. Okay. There's a comminuted fracture here, and the limb is almost completely amputated. Okay. All the segment of muscles which are there, the circumferential soft tissue loss. The muscles of the anterior, lateral, posterior compartments, all are segmentally lost. The important thing is the posterior tibial artery and nerve are intact in all these injuries. And then here a strong motivation which was present to save the limb. That is the only reason why we told, okay, we'll go ahead and try. The parents were strongly motivated. The patient was strongly motivated to this thing. So what we did is, first we debrided the wound. Okay. After debridement, we put in an external fixator. External fixator. After that, we put in LD flap. Again, it was split LD flap to cover the entire wound. And then there's the patient. Patient had financial constraints after that. So he was there in the bed at home, dressing the wound. In 1 year, the wound healed. They didn't have money. Okay. So that's the important consideration. Okay. Then 1 year later, we put in Elizarov. We transported the bone, and the bony union has taken place. You can see now that this is the fixator which has been applied, and this ring from here it has traveled here. This ring, you see this third ring which is here above, that has carried the bone, and there's the regenerate which is there. If you see, there's a lot of regenerate which is there in this. So the same patient around 2 years down the line after the initial injury, and all the wounds have healed. Is able to bear weight and is able to walk. But still, if you see the previous picture, 1 second. Yeah, if you see the previous picture, there's a small amount of angulation here. That's why he's having a little bit distinct. Plus, he has got loss of muscles in all the compartments. So the functional outcome which you expect full control may not be so great. But in lower limb, the amount of functional means requirement which you require for the muscle groups is less. That is why, unlike hand, in lower limb, if you save, the patient is usually able to walk well. Okay. This is another case. It's a late presentation. Patient is a 49-year-old lady. She has come from a different country with a fracture, with bone loss, 1 week to 10 days after injury, and the antitibial artery and nerves are lost. The anterior compartment muscles are lost. There's an extensive bone exposure which caused this bone to die. This bone could have been saved if there was an early cover, but because of prolonged exposure, that bone has died. Okay, and there's loss of ankle extensors. Okay, so this is how same thing I mentioned again. That there's a late presentation. Exposed bones are dead. Extensors of tissue loss there. Loss of extensors, and there's an infection. So how we went ahead with it? We debrided the wound. We applied an external fixator. Already the external fixator was there. We just redistinct. Then we gave an LD flap cover. LD flap cover was given immediately. Okay. After that, we did a grafting for the patient. Then you see that there's a distal necrosis in LD flap. Yeah. That distal necrosis is very common in LD flap because LD flap, the distal 1/4 is little bit precarious. Not all the time it survives. So if it doesn't survive, what we do is we just shorten the limb a little bit, advance the flap and cover the defect. That's what we did here, and the wound has healed completely here. So next, we applied an Elizarov. You see this ring here? You can see this ring here. This is carrying the bony segment. There's a small bony segment in the fracture. There's a fracture here, and this is the bony segment which is there. You can see this bony segment? Yeah. So this bony segment was traveled down here till here. So that much of bony regenerated has formed with the bone transfer. And there's the same patient, and if you see her, she is walking here. I don't know whether you saw the video. That's one thing. The video is not working again. Okay, no problem. She is walking and bearing weight on it, and the wounds have healed. Okay, yeah, you can see that the patient is able to bear weight and walk. Okay, this is another case. Here, there's a 29-year-old gentleman who had a bike accident. Most of these accidents occur because of two-wheelers, because most of the people are in two-wheelers and they're easily injured because two-wheelers don't protect these people. So he had a head-on collision with another bike, and he was advised amputation in another hospital. So to save his limb, he happened to come across this. The problems are there's a comminuted fracture in the leg, there's soft tissue loss in the anterior aspect, there's associated foot injury here, and there are associated some clavicle fracture is there. He had a resolving hepatitis also along with it, and there's a plantar skin avulsion also which was there. Okay. So with this, we first went ahead with debridement. See, all these patients have a similar sequence. They undergo a radical debridement, they undergo external fixation, then they undergo a soft tissue cover, then they undergo bony reconstruction. This is a sequence in all of them. None of them have a different sequence, unless we'll see something else. Okay, so this debridement is done. Initially, we put a VAC to buy some time because he has a resolving hepatitis. Okay, then we put an ALT flap here, which covered the wound. And then later on, we had to undergo a bone grafting and plating for him. And this is him. There's him around 10 years follow-up down. He's walking nicely, and he has got what we say, he's able to ride a bike, and he's basically independent. That's what we want. Patient should be able to bear weight, walk independently, and carry on with his activities of daily life. Okay. So he has some edema in the lower limb. That is because of the amount of injury which he had sustained. Okay. So another case is a young boy. He has a bad injury in the lower leg. It looks like a small wound, but it is not a small wound. It's a complete circumferential degloving at this level. All throughout around the ankle, there's a lot of tissue loss. Okay. There's a both bone fracture here, and associated head injury and femur fracture also there. Okay. So this is how the wound has been debrided. You can see that the wound is there all around the ankle. We have put an external fixator here after debridement. Then we went ahead and did a split LD flap. One part is covering the lateral aspect, one part is covering the medial aspect. So the wound has healed here, and then we applied an Elizero, and then it has gone to your bony union. Okay, and we do not advocate the use of fibula for reconstruction of bony defects in lower limb, especially because if the fibula fails, then secondary reconstruction becomes very difficult. Cross leg flap goes out of an option. Bony reconstruction becomes very difficult afterwards, because especially if you have a large soft tissue. If your soft tissue defect is very less, then you can go ahead with fibula. But if you think that the soft tissue defect is also big and you want to reconstruct with the fibula, then you are burning out the other options. Okay, the same patient at 2 years follow, everything is healed and bony union has occurred and he is able to walk. You can see that the slight angulation in the ankle level, about the level of this thing. That is what is causing his gait to differ. This can be corrected, but again, the patient has to afford. Affordability is one thing which is this thing. Okay, so there's a simpler case. There's a case which I am telling, which anybody can manage. What it is an 18-year-old boy. There's an open fracture. There's a gastrocnemius soleus loss here at this level. Vascularity is intact. There's a simple fracture which is there. So such patients will have better results because the injury extent is very less. So we debrided the wound. You can see the bone fracture site is exposed. Then this soft tissue, we preserved it there. It survived. We put an LD flap onto it. It went on to heal in the external fixator itself. There was no need to change the external fixator. Union occurred, and you can see that the good ankle movement. This all happens because the muscle groups are intact. If the muscle groups are intact, you'll have a better functional result. If the muscle groups are bad, then the functional result is bad. And same thing, and let's say he's able to run. Like it is around 1.5 years that they're down. He's got full movements and he got back to this thing. And the bone has united. So this is a case which came to us from Chennai. Okay, so he is one of my friends, my seniors, whose cousin was involved in a bad accident. He was run over by a heavy vehicle, and there was a bad injury with compromised circulation. But luckily, the bones were not fractured. But if you see that a lot of a lot of bones are exposed. The long length of bone is exposed. He had underwent a primary debridement at Chennai and then came to us. Okay. So the distance circulation was poor. There are a lot of muscle tendon units which are lost here, and he was shifted from Chennai to Bangalore. Okay. So there's the extent of tibial which is exposed. You can see from almost from the knee level to the ankle level, it was exposed. There's a lot of degloving of the posterior skin also. So for what we did is we debrided the wound. Once the wound was debrided, we put in a split LD flap. You can see this LD has got one edge which is going proximally and one edge is going distally. So to compensate for the length, we have used in such a way that a split LD covers both the proximal and distal part. End to side anastomosis was done, and then the grafting has been done. Okay. Now the problem comes is the secondary part. The distal part of the LD is not always reliable, so we had a loss of LD in the distal part, though the proximal part everything has survived. So what we use is there was the posterior skin which is available here. We use this as an adipofascial flap and just covered this area. See, you can see the adipofascial flap just covered here, along with that. Okay, with that it has healed, and this is around 8 months later. Here you can see him. He is standing. Everything is healed, and this is the same patient. Around these are 3 years. You can see that the 1 second. You can see the ankle movements are good. Okay, and one second. This video. Okay, no problem. Take care. So he's able to walk nicely and he had no problems. And there's another case. He's a young patient. Again, he was run over by a heavy vehicle. Similar, all cases are similar, so that you have an idea of how it is done. So his wound was right from the groin region to the ankle, with degloving all around, bone exposure, and in shock he came to us. Okay, the segmental loss of the posterior artery here, lot of muscle tissue which is lost, and there's a pelvic fracture along with it. Okay. So what we did is first during the first debridement we put a skin graft on the thigh. This is to reduce the amount of wound which is exposed. If the wound exposure is less, then infection chances are less. Then in the second setting, we went ahead and did an LD flap to cover this entire area as much as possible to cover the bone. This LD is looking pale here. Then again we grafted it. Some amount of tendricles is exposed here, that we excised and closed it with a graft. Again, this LD debrided and grafted, and then everything is healed now, and the patient is able to stand and walk. This is 1.5 years afterwards. The problem with him was he again had financial issues, so we couldn't go ahead and intervene right on time. We had to wait and get the clearances and get it done. Another case, the open fracture of the tibia, segmental fracture. So here he had a femur fracture along with it, with bone loss. So that is the femur fracture. This is a tibial fracture. The tibial fracture was opened up. Everything was aligned back. External fixator was applied. Then an LD flap was given to cover it. The wound has healed, and then all the fractures went in for union, and the patient is able to stand. If you see him now, he is able to walk, but he has an intercondylar fracture of the tibia also, with dislocation at the subluxation of the knee. That's why his gait is not so good, because he had a fracture around the knee. You can see the screws here. Here you can see the screws which are there because of an intercondylar fracture. Here a tibia fracture, here an intercondylar fracture, and a femur fracture. All went on to union. This is a case which is very interesting. So this is a young child, 9-year-old child, was referred to us with a grade 3C fracture tibia, along with a heel pad avulsion. There are two defects here. One is a tibial defect, one is a heel pad defect. This is a heel pad which is completely cut off, but they have just sutured it. It's referred from one of the medical colleges. So there's loss of circulation. There's a heel pad loss. There's an open tibial fracture here, and there's an unknown time of ischemia. Okay. So unfortunately, when he came to us, We saw him, the circulation looked intact. Okay. We readjusted the fixator, saw everything looked fine. We told, okay, everything looks fine. Maybe they didn't diagnose it properly because SpO2 was picking, pulse was there. We told, okay. We put the external fixator and went home. Next day morning, we came, the limb was cold. There was no circulation at all in the limb. We didn't know whether the circulation was when the circulation went off. We didn't know anything. Okay. Then also, what we did is we told, okay, let's take it a chance. The parents are very anxious. They told, save the limb, save the limb. So we went ahead. We just revascularized the lower limb with repair of posterior tibial artery and anterior tibial artery. Both the arteries were repaired without knowing the ischemia time. Okay, because overnight only. So we thought maybe 7 hours. So then we were able to restore circulation. You can see the below the circulation has been restored below. Then we went ahead and took an ALT flap on this child, put an ALT flap, covered the tibial defect. Now, once we knew that the ALT flap is surviving, then we went ahead and did a cross leg flap for the heel flap because they got second defect. We don't want to we can't do another free flap in a patient who has been revascularized. Okay, both the arteries have been revascularized. So we put out a cross leg flap, and the cross leg flap healed. This is around, this is all healed without infection, and all went out. This is around 2 years follow up in stable coverage. Then WhatsApp only he has sent the pictures, but he's doing fine. Otherwise, he's doing fine. Okay, this is another case where the open grade 3B fracture with a failed reconstruction. Means somebody has already attempted a cross leg flap, which has failed. He has a bone exposure. There's an infection. There's a skin grafted lower limb, and even the skin graft donor site is not healed. There's a skin graft donor site which is not healed. It's come with all this. So the problems are there's a bone loss, there's a bone exposure, there's a failed cross leg flap, there's an infection, and a skin graft donor site also not healed. So if you see here, there's a bone gap. There's a bone exposed, which is seen, which is here. There's a bone exposed. So what we did, we debrided the bone, and we put an LD flap to cover it. LD flaps in children are smaller; they are not very large. That's what we found. The LD flap which you get is this. So with that, we are able to cover the wound. The wound has healed. Then we put in a elizero, and which went on to bony union. And this is him healed. Everything is healed. No infection. And this is him going back to his country. He's in the airport. I met him in the airport because I was traveling at the same time. I happened to meet him and took a video. Okay, so he's going back to his hometown. There's another case which is still going on. It is a fresh case. Okay, we got it in January. So he's not an 8-year-old. He's around 28 years old. 28-year-old boy who has a compromised circulation in the lower limb. There's a CT angio showing this compromised circulation. There's an extensive wound involving the leg. Okay. So this patient was referred to us from orthopedics. They wanted to save the limb because it was his relative, the hospital owner's relative. So he wanted to save it, so he sent it to us. So this is how we debrided the wound. All the wounds were debrided. Then we put an external fixator. By the time we put an external fixator after debridement and put a lot of xylocaine, the circulation got restored. Most probably the vessels were in spasm. Antitibial vessels was lost. Okay. So with this wound defect, we went ahead and gave an LD flap with the enteroside anastomosis. Okay. Because we were not sure about the circulation. So we had to do an enteroside anastomosis. Not 90% of times we do enteroside only. We don't do end-to-end. 99% is enteroside only. Okay. So with that, we covered the wound. You can see the wound is covered. Then we grafted the wound. Everything looked okay. But after a few days, we noticed the distal part of LD is gone. You can see the distal part of LD. There's a loss of tissue. That's which with bone exposure. So then we went ahead. We did a re-debridement of the distal part. Then we put a cross leg flap. This is a cross leg flap. The cross leg flap is now covered. It healed with infection because there was a delay and there was long bone exposure, long segment bone exposure for a prolonged period of time. So the bone has got devascularized. So we had to remove this amount of bone has been removed. Okay. So, but it ultimately healed. Then we put in and there's a elizero which has been put here. You can see that the elizero ring is here down, and with the transport, the regenerative is forming here. Regenerative is forming. The ring is moving. See, the ring is moving from down to up. Here it is down, it is going up. So it's carrying the bone segment above. And the region rate is good, and we are expecting him to heal shortly. Okay. So next we come on to compound defects around the knee. So there's a common thing which we commonly find that around the knee there's a loss of tissue and joint exposure. Sometimes other thigh also is having a amount of injury around. So here we ask the patient whether he will be willing for an arthrodesis for the knee, because the knee joint was exposed and there was loss of articular surface in the knee joint. But the patient was firm that he doesn't want any arthrodesis in the knee. So that's why we had to keep the knee mobile and cover the wound. Okay. So we debrided the bone. You can see that the articular surface loss. There's a loss of patella. There's a loss of femoral bone surface. There's a loss of tibial bone surface. We offered him this thing, but he was not willing. Then we harvested the ALT from the other side, other thigh, which was having a friction burns. You can see the friction burns are here. These are all friction burn areas. We took then we put the ALT flap on this. It went on to heal very well. Then he's back on his feet. Though he's laughing in this picture, but he has pain in the knee. And because of the loss of articular surface, he has a lot of pain, and he keeps on asking when I can go for a knee replacement. Okay. So that's him around 4 years down. The wound is stable and the coverage is good. And even the skin color is improved after a period of 4 years. Even if you see the graft donor side area, also the skin color is improved. Another case of a knee joint injury. Here the knee joint is injured, but there's a lot of soft tissue degloving on the lower aspect. The knee joint is open. There's a fibula head which is fractured. So this patient what we did was we fixed the knee. The collateral ligaments were reconstructed because the lateral collateral ligament along with the fibula was damaged. Then we gave a cover of gastrocnemius for him. The gastrocnemius flap cover was given. That lateral collateral ligament was reconstructed. Then we grafted it. You can see that the graft has occurred. This is the first picture, the second picture with the grafting, and this is the healed picture. And the same picture around 8 years follow-up. If you see him, he's able to walk nicely with the leg, and even he is able to squat and get up nicely from the leg. So important that you maintain good relations with the patients and keep them on follow-up. Then only you can see what's a long-term follow-up. Okay. The take-home points are basically that radical debridement you have to do. You have to do a good debridement when you do it. Any devitalized tissue, you must remove it. Any devitalized bone fragments, you should remove it. If there's a long segment bone exposure, then you should expect a sequestrum because of loss of circulation in the long segment of exposure. Re-establish circulation if possible. If the patient has come in time, you feel that yes, you can do it. Do a revasculation of the limb. Give a good wound cover, then do a bony reconstruction. Secondary reconstruction after bony reconstruction, not during bony reconstruction. Okay, thank you. Okay, I have some more pictures, but if you want, I'll show you. Okay, okay. So composite defects on the foot and ankle. So this is a young patient. This is a very common thing which you have always have heel pad avulsion. So here there's a fractures around the knee joint, means the ankle joint. What do you say? Okay. So same thing, same principle. Debride well, fix the bones, give a soft tissue cover, it should heal. Here you don't require any bony reconstruction because the bones are all done and all are dealt with in the first instance. So here debridement has been done, bony fixation has been done, flap cover has been given, and then he's walking around. So he's walking well. And you can see that the good contour of the muscle which comes. There's a single gracilis flap which has been done, and you can see that the contour settles down very well. Though the color match is not good. This color match may improve with time. Okay. Another case, combined dorsal and plantar skin avulsion. You can see here, dorsal skin is also lost, plantar skin is also lost. So again, here the choice was not good because the ALT flap was a bulky patient. The ALT flap was bulky. It's not good for the heel with the bulk. We did a ALT flap. Flap took up well. We had to do a vein graft for the artery and vein both. And later on, we did a flap thinning. Everything healed. This is around 10 years follow. The same patient. in such patients, nerve injuries, if they are there, they should be reconstructed. You can see that the clawing in the foot. That all happens because the associated nerve injuries may not have been addressed at the time. Later on, you should think of addressing the nerve injuries. If you don't address the nerve injuries, you will end up with clawing. So unfortunately, we didn't do it, and this is how she's bearing weight and walking, but she has some deformity in the foot, which doesn't look good. Okay, so that's the one, and this is a walking. Unfortunately, the video is tilted. Okay, okay, so she's able to walk around. This is around 10 years after the injury. This is another case, a driver by profession run over by the same bus which is driving. He was trying to repair the bus sitting down. Somebody came and drove the bus behind, reversed the bus. His leg was run over. So he was a driver by profession, so his foot was important. So we wanted to save his foot. It happened to be one of my earliest slip ups. So finance was taken care by employer. So the problem was circumferential degloving. There was a Lisfranc joint dislocation and a large flap which was required. We did an LD flap. We were able to cover part of the foot. With this, with the customized footwear, he was able to walk independently. He was able to get back to his job, and he was able to walk independently. That is what is the purpose of the reconstruction. Though his toes could not be saved. Another case, degloving injury with Lisfranc joint dislocation. The plan was debridement, fixation of fractures, LD flap level. So here what we did is we debrided the bone, we fixed the bones with KYS, took an LD flap, we split the LD flap. This is how we split the LD flap along the vascular pedicle. Once this thing is done, one part was used to cover the heel pad, other part was used to resupport the dorsum. And this is how we maintain the position in the post-op, where we keep it elevated. And this is him around 11 years follow-up with a stable coverage. He's able to walk around both with footwear and without footwear, and with a stable coverage. Then there's infections. Sometimes you have infections after fixation. So you can debride it and put a flap. That should heal. Another case of a similar post-operative, post-plating. These are all post-plating. So again, and it can be done. Okay. Yes. The next. Okay. Yeah.
Questions will take for this. Otherwise, there will be confusion. Thank you, Dr. Jitendran. Excellent talk, the experience. Usually, plastic surgeons they work like a team. So we take the help of orthopedician right from day one. And since Dr. Jitendra has the dual advantage of orthopedics post graduation and also plastic surgery, so that is how with the two weapon in the hand, he has shown what it can do. So in a scientific evidence based reconstruction, we need to follow the guidelines. And I'm very happy that those guidelines which we teach our resident, he has covered almost all the 19 points of the guideline. We have a BOST guideline, which our resident, we tell them. We have put a chart also, the British and the orthopedic combined guideline. So they revise it every 5 years. So the last guideline, post 4 guideline has come, which was released in 2020, just 2 years back. So if you see that guideline has a 19 points, and exactly with his experience, he doesn't need any guideline. He himself followed beautifully. I am sure he must be gone through those literature, and right from the immediate management, life-threatening management, planning, execution, rehabilitation, documentation. So thank you very much, Dr. Jitendra. It was really nice to hear from you, and the eye-opening that, and to you and to your team also, because sometimes you are working alone, we know, but sometimes really you need a good team to give this kind of result. With this, we have another lecture by Dr. Jitendran, which is a surprise lecture on reimplantation, distal reimplantation, how you can get success. So we have two options. Either we can take the second lecture, or first we see the chat box and see if there is any point to be asked by our participants on hybrid mode, and then we can go. So I feel let us close this chapter here only, because the distal reimplantation will be another uh, very important topic for the plastic surgeon. So let me see the chat. So there are 10 points I can see in the chat. Let me go through the from the top. So Dr. Vishwajit Mishra, he has asked for middle third defect. What is the recipient vessel? So please take the Kavita, give the mic to sir, Dr. Jitendran, and focus the camera towards her. Sir will give the his experience. One third defect. What is the recipient vessel? Usually, what you say?
There are only three things which we take care of. One is posterior vessels, anterior vessels. The peroneal vessels are usually not accessible. So anterior or posterior are the only ones which are optional, which are there. If there is a zone of injury in the anterior vessels or the posterior vessels, which will not give you a good vessel, then you can go posteriorly using the Gorina and then get the good vessels proximally.
Let me check whether mic was working or not. It is working. Yeah, because it should not happen. The purpose is not served. And Dr. Satya Swarup Tripathi from PJ Chandigarh, he is saying it is congratulating you for the excellent talk. And his question is, do you fix the fracture and then do the reconstruction in the same stage? How do you decide about the quality of recipient vessel?
Quality of recipient vessel is decided by ease of dissection. The vessel should be easily dissected. If the vessel is easily dissected and looks good when you cut, then it is a good quality vessel. You should be able to see the lumen very clearly, and you should be able to dissect the vena contents very easily. If you are able to do all these things, then the vessel is usually good, and you should have a good pulsation. Then it's a good vessel. If the vessels don't have good pulsation, or there is a difficulty in dissecting the vessels, that means that you are still in the zone of trauma.
Thank you. And this is a very important question. Usually we ask in the MCH exam also, the concept of zone of trauma and taking the decision. So thank you for covering that perspective also. Further, Dr. Vishwajit Mishra would like to know, for circumferential tissue loss along the entire length, have you used correlate loop, AV loop?
Maybe till now we don't have the opportunity to use, but surely it can be used. There's no problem about using AV as long as you are okay to use a vein graft both for the artery and.
Correct. So sir is right. If opportunity is there, and you can always use AV loop also. And Dr. Surya is saying, was the posterior tibial nerve intact in all your patient? As you were mentioning about nerve injuries to be taken care. So what?
In our patients, they were intact, so we didn't have much of a problem. But if it is injured also, we can always go ahead and repair it with the same.
Okay. So luckily you had the intact posterior tibial nerve, otherwise primary or maybe secondary, but Dr. Jitendra feels is better do a secondary reconstruction than the. And then, yes, you're right. Yes, why to do? Okay, then Dr. Nitesh Reddy, his question is, what is your experience with the reperfusion injury in a delayed revascularization?
See, whenever you are doing a delayed revascularization, you should see the limb properly. The limb should not be under rigor mortis. And even if there's a flicker of movement in the limb, then you will not have reperfusion. If there are intact muscles in the limb which are revascularized, it will not undergo a reperfusion. The only time when you land is when you don't assess the patient properly. Otherwise, you will not have reperfusion.
Thank you. Dr. Pooja Mistry would like to know intraoperatively how do you decide the area for vascular anastomosis?
Have dissect the vessels proximally. Then once you go to an area where the vessels are easily dissected, they are out of zone of injury, then you can easily go ahead and do it. But don't do it in a zone of injury because even if you do a very good anastomosis in a zone of injury, it is likely to report problems.
Dr. Naljoy is our MCA student who last year passed out. Now is in Tata. And Dr. Naljo wants to know, do you use flow-through flaps?
Flow-through flaps are also used in both in upper limbs and lower limbs. We have used whenever there is a requirement, we use. But if there's an intact circulation without the requirement for vascular reconstruction, then we don't require.
Thank you, sir. And Dr. Amrika is wishing you for the good talk and the result which you have shown. Dr. Arvind Osamani would like to know that in your experience in dermal templates or the skin substitute in acute as well as delayed presentation of the leg defect, what do you do?
In leg defects, we are not used with dermal templates, but we have surely used it in foot defects. Foot defects, we have used dermal templates to bridge small defects which otherwise would require.
Yeah, because here in JIPMER, we are very fond of substitutes and the dermal template. Let it be any place. If it is available, usually always it is available with us. It helps into the many times gaining the time, making the wound ready, and also preparing the patient for the delayed reconstruction. Otherwise, in acute cases, anyhow, it is a substitute. That is the principle. Thank you. And Dr. Neljo is also wishing you for the excellent presentation and super photographs. And Dr. Vamsi Krishna Madhu, he is saying that Ilajero takes too much time. What are the options if he wants earlier reconstructive option? We know that the Ilajero or destruction methods always takes time. So in plastic surgery, time is not a important, result is important. In hurry, you should not make it very. That I would like to add here only. But his point is pertinent. Then, in case you want early, what to do?
No shortcuts. There are no shortcuts. We have to use the option which works well in our practice. If either works well, the rate is usually good, and within a short span of time, with the result you can still walk. There's no need that you bedridden, and with a good regenerative which forms with an Elizabeth, usually the reconstruction is completed.
Yeah, usually orthopedicians love to have Ilijaro and destruction method, more so because you are not using any bone grafting, you are saving the bone for future usage. So if patient agrees for a time constraint, definitely Ilijaro has an edge over the conventional same time primary bone reconstruction or delayed reconstruction. And sometimes it may not be feasible at the same time because you need an orthopedician or sometimes you are doing free fibula from other side. So keeping those options, you should put up to the patient that time versus risk they would like to take.
If the fibula fails, then you don't have even a cross-section as an option.
So that is what I was just going to say. So one should be very careful. Safety in plastic surgery is more important than the hurriness or the fastness. Safety should be always kept in the mind. Once you lose it, very difficult to retrieve it. Dr. Vijay Jagannathan from PIMS is our professor of plastic surgery in Pondicherry, and also we have a Pondicherry Plastic Surgery Club. Today he has not come because he's busy, otherwise usually he participate here. He's also wishing you for the excellent talk, and also he's asking about Godina approach.
Godina approach is one approach we use very commonly, especially when the injury is quite proximal, because it will be difficult to get good blood vessels by dissecting only the posterior vessels from anterior or middle aspect. So posterior approach helps us get good blood vessels from the point of origin, that is a properly.
Yes, thank you very much, because this is a standard question we ask in the MCH exam also, Godina approach and its implications. As you have shown in your presentation, mostly you are getting distal LD flap, but the question is very generic from Dr. Surya that of course complication can be right from the wound infection to losses and everything. So what other complications commonly you have encountered?
Commonly, we have encountered hematoma is one common thing which we have seen. Other thing which we have commonly seen is infection and sequestrum formation, especially when there is a long bone exposure. Sequestrum formation has been seen, infection has been seen, persistent draining sinus, and sometimes patients have late cellulitis in the limb.
Thank you. Because the number of questions which are raised, that itself shows the interest of the participant and the interest which you have generated. Both way, it is important that audience and the speaker both are getting the good outcome of this lecture series. With this, we would like to close this part of the session, but we will continue with the another session which was not planned but on request, because we have been seeing his a lot of in the groups and otherwise also his experience of distal reimplantation. So, sir, please start your second part of the presentation.
Fingertip presentation. Hi. So there's a topic which is close to my heart because I like to do fingertip implants, which help us improve our microsurgical skills, and also they are very common injuries which come on. Yes, one second. Is it okay? Yes. Okay, that's it. Okay. Fingertip injuries are very common, and fingertip replantation is one thing which can be done by everybody, because everybody will get an opportunity to do a fingertip replant if they decide to do it. As these injuries are common and happen everywhere, and everybody can get an opportunity to do this type of replantations. So next slide. Right. Yeah. What is a fingertip replantation? Fingertip replantation is basically defined as complete amputations in which the replantation is done either at the distal phalanx or distal to distal interphalangeal joint. So DIP joint and beyond is distal replantation. So coming on to this thing classification, commonly we follow Tami's classification. We say before the lunula, distal to lunula, and proximal to lunula. So proximal to lunula is that called the Tamai 2, where you can easily find dorsal veins. If you find dorsal veins, the replantation remains as a classic replantation. But if it is distal to that lunula, then you have to find the volar veins. Okay. So coming on to the arterial anatomy, there are two arteries. One is one second. Yeah, there are two arteries. One is the radial artery, one is the ulnar distal artery. Both of them, they form an arch. Then they give out a central distal artery. That is what it this one. Okay, that's what you are seeing. The nerves usually come medial to it. Okay, so this is how it is. See, here they bifurcate. If you see here they bifurcate. Here the arch which is formed. Here again there's a bifurcation. The nerve is going straight, and here the arteries are giving branches. Okay, and there's a DIP joint crease. Okay, there's the arterial anatomy. Here they are dissected. This is not my slide, but somebody else has given this slide. So there's a dorsal dissection. There's a volar dissection, and there's a dorsal dissection. Dorsal means beneath the nail bed, and this volar means over the flexor tendon. There's a flexor tendon here. Okay. So here in the volar side, it forms an arch from which there are multiple arteries which are given out above. Okay. And in the dorsal side also, at the level of the DIP joint, a dorsal branch is given which forms an arcade just at the base of the nail, and one arcade is formed at the distal aspect. these both arcades, they again intercommunicate with the volar arcade. So that's how the blood supply forms. So that's what is given here. Okay. And these are the dorsal veins. When you have the dorsal skin, you can always find the dorsal veins. Dorsal veins have got different patterns. They may form a single vein in the dorsum, or they may be multiple 2 or 3 veins. The problem with 2 or 3 veins is if there are multiple veins, the size will be smaller. If you have single vein, the size will be bigger. So this okay. This is how we expose the volar veins. Volar veins are exposed by reflecting the skin of the volar surface. Then once you expose, then you can see the veins, one in here. I don't think it's very clear here, but you can see the veins. Okay. So what is the technique is? First is you take the part. We don't wash the part. Typically, we don't wash the part. We don't wash with saline. We don't wash with any betadine. Nothing we do. We just take the part directly on the table. We start dissecting it under microscope. Debridement is done after identification of the structures, not before that. So washing is done after identification and tagging the structures. The importance is we are able to identify the structures. If you wash it in tap water or any saline, the blood from the vessels goes off. And then it becomes difficult to identify the vessels. If the blood is there in the vessels, it's easier to identify the veins and the artery. If it is not there, artery is still identifiable easily, but vein, if it's without blood, then it becomes difficult. Okay. So the other precautions is when you are doing a distal replant, no tight stitches. Don't try to close each and every defect. Leave it open. Put skin grafts if required. If there's a short arterial, don't try to anastomose under tension. You do a vein graft for the vein or the artery on table itself. Don't try to tie it up with very tight. Okay. Keep the limbs exposed and avoid very cold temperatures. Though we use AC quite often, we don't deny the person of AC, but still it is recommended that you keep the limb warm. Okay. So this is a case of a thumb amputation. There's a very common one where a patient is cutting a coconut or something like that, and he has cut his thumb. Okay. So here we have done 2 volar veins. So in this small area, which is you can see, we were able to do 2 dorsal veins. Okay. And this is him after the thumb has survived. There's no heparin or aspirin which is used. No anticoagulants we used. And this is him afterwards. This is around a year afterwards. So he's able to use his thumb. It has healed well. If you see this black spot which is here, that is a skin graft. We actually use the skin graft to cover the volar area. We don't try to close the wound. There's another case, the ring avulsion amputation. It's happened to one of the doctors. So he's a HOD of one of the good hospitals. Okay. So he had a freak accident. He was sitting on a bike. He just fell down and had two finger amputation. One finger was totally amputated, the middle finger, but the circulation was intact because it was just an avulsion, but the ring finger was completely amputated. If you see here, that the nerves are all completely avulsed. Okay, so this is how we do it. First, we do the artery. If you see here, there's a bleeding from the distal part. Okay, once you have done the artery, first you do the artery. You can see that there's a good distal bleeding from the distal part. Okay, then once you know the bleeding is there, then you can identify the vein. From where it is bleeding, you can identify the vein. Then you put in a vein graft for the volar aspect. You take a vein graft from the distal end and connect it to the proximal. Proximally, it's not difficult to identify the vein, volar vein. But distally, once you identify the bleeding from where it is applied, then you can identify the vessel and you can easily do a vein graft. So this is the same patient after 2 months. So you can see that the finger has completely survived and slowly he's improving its function. Okay. Another case of a bike chain injury. Here is the distal amputation here. So it's completely covered with grease. You can see the fracture, the amputation is distal to distal phalanx. So this is a proximal stump. So we dissected the vessels. Means vessels are dissected. This is a vein graft which has been put on the volar vein. Single volar vein has been repaired with a vein graft. So this is in the post-op, you can see the finger is quite pink and doing well. And this is him at 1 month follow. So everything is healed. There's a small graft which has been put. These all black spots are the graft, small skin graft which has been put. So it has healed, and you can see the function which is good. Okay, so you are able to salvage such patients. Okay, so this is a 2-finger amputation again. So here, this is in zone 2. This is a proximal amputation. This we are not bothered. So here, what happened is, if you see here is a distal amputation, distal to the distal interphalangeal joint. So this is done as standard one. The middle finger was done as standard one. But for here, we at the time we were not able to identify the volar veins. So we just did the artery only anastomosis and did a chemical leaching, and with that, the finger has survived. This is the case as again you can see it's to the distal phalanx, distal interphalangeal joint. There are 2 fingers. Here no heparin was used and it has survived. Same here, dorsal veins were available, so it's easier to do it. This is the case of a distal replant. Here there are 2 fingers. Only 1 finger was brought to us. The other finger was not brought to us. So here 1 volar vein and 1 distal artery, it survived. Other finger was terminalized. This is another case. Same zone 2. Stomach zone 2 is through the distal phalanx, distal interphalangeal joint. So it was repaired. Dorsal veins are repaired, and the standard volar vein was repaired. Inside volar artery was repaired. If you see here, there's a common problem which is there. It is rotation. This finger doesn't look good because it's rotated. There's a rotation in this level. So when you are doing a replant, you have to be very careful that the finger doesn't rotate. This rotation problem is very common, which is not usually identified at the time because we're in a hurry to do the procedure. But you should take time to do a proper fixation so that the rotation doesn't happen. If the rotation happens, it doesn't look good. Okay. So this is another case, bike chain injury. There's an aversion amputation. Same again, dorsal veins are easily available here, so you can easily do it and you can get back. Middle fingers are obviously not brought. They didn't bring the middle finger. Another case, bike chain injury, amputation. Here, dorsal veins are easily available because there's a long segment of dorsal skin is there. You can easily do the dorsal vein and it survives. Okay. Why we do a fingertip replantation? One is they are easily available. You get to do a fingertip replantation whenever you want, because in any emergency you'll get 1 or 2 of these fingertip injuries, which can be easily replanted. Okay. Our cosmetic and functional outcomes are very good than with the other means, and satisfaction of the patient is very high. And what will maximum happen? You lose the fingertip. Okay. You can always reconstruct it later. Okay. So it's not a problem. Okay. Complications, sometimes we lose the finger. Here 1 finger survived, 1 finger has not survived. That's one of the complications. The other thing is sometimes you have partial survival. The injury is more. In this case, the injury is more. Part of the finger has survived, part of the finger has not survived. This also can be reconstructed. It's not a problem. You can reconstruct these injuries, but the patient should follow up. That's all. I'll show you an example. So this patient had one of our recent patients taken. So this finger was there. Thumb amputation. Thumb amputation anyhow is an indication for replantation. So we did reconstruction for the artery and vein with vein graft. Both artery and vein were reconstructed with vein grafts because it was not possible to get a direct approximation. So initially it looked good. For first 6 days it looked good, nice. Later on, we found that there was a large amount of tissue necrosis in this thing. At the end of it, we landed with like this. The tip has survived here. The nail bed is gone. The volar aspect also is gone. So what we did a cross finger flap. With the same cross finger flap, we resurfaced the volar aspect and the dorsal aspect. And then see if you see the nail bed has taken up well and the finger has been separated out. So we did a nail bed grafting on the cross finger flap. And this is a separation and he's doing well otherwise. Another case, again pediatric replantation had failed. This was again reconstructed. Patient is having a follow-up, but I have not added the picture. Okay, so how do you do a post-operative management? Only thing you can do, one is direct color this thing, and other is Doppler. You can do this thing. Most of our staff, they send photos by WhatsApp. So we just have a monitor and they do a Doppler because we leave the Doppler with them. Okay. And no special medication are required. And these patients can be discharged the very next day after doing a replant. You don't have to make them stay back in the hospital. Next day you can discharge them if you are okay. Okay. Non-replantable fingertips. Suppose if they have non-replantable fingertips like this, where you are not, you didn't find the vein or artery, or maybe the same. So we harvest the nail bed and the bone, and then we put the nail bed across like this. Bone graft we put, then we do a cross-finger flap. And if you see there's a good nail bed growth, good nail growth, and good function of the finger. Similarly, Similarly, another case, you can see double level injury in the fingertip. Now, not a good candidate for a replantation. Again, nail bed grafting and cross finger flap. You can see a good nail bed growth here and a good function outflow. These fingers do well. Another case, ring finger injury, not replanted because of financial issues. Again, we did a cross finger flap and nail bed grafting. You can see that the nail growth is very good and the function also good. Only thing you have is the color here is not good. This color doesn't look good. So nowadays what we are doing is we are not doing cross finger flap. We are basically doing a thinner flap. Thinner flap basically gives a better color. And so why we do it is because there's nothing to lose. Operating time 3 to 4 hours. Blood loss is not a problem. And it can be done in regional or local anesthesia. And you can discharge the patient also fast, so he doesn't occupy your bed. Pitfalls is basically all fingertips cannot be replanted because if you have a problem with the vein, then you can't do a replant. Then you have to do chemical leaching, and you can determine whether it's replantable or not only after dissecting under microscope. So you cannot directly tell them that it's replantable, not replantable. But if you put in effort, you can replant almost everything. But the amount of effort which you have to put to make them survive also should be taken into account. Ideal candidates are always not found, like sharp cut amputations you will not always find for replantation. You'll always have to do replantations in patients who do not have a sharp cut amputation. Okay. Mentally unstable patients are a contraindication. Smokers are not a contraindication. Okay. Long warm ischemia time is not a contraindication. Okay. The other case is a non-replantable. So, but in this hand, we just found the thumb is also injured. Though these fingers are not replantable because of multiple cuts, we found that the thumb requires some coverage. So we took a pulp out of this and we were able to cover the thumb. If you see the thumb has survived here, we put a groin flap on. So later on, this patient undergone splitting of the groin flap and other things, but they didn't follow up because the logistic was a concern. Thank you. Yeah. With the chat box.
Thank you very much. It was indeed an excellent presentation on the most common emergency. The most common plastic surgery emergency is fingertip injury, and I was sharing my views that in 1994 my thesis was on fingertip injuries, and that time I was reading Dr. Venkata Swami book, Fingertip Amputations, and then we developed our own classification of fingertip injury. But unless you publish it, I published it, so it is there, but did not got popularized. And technology has taken really all of us far we thought of because of the super microsurgery, good magnification, facilities available. So now the time has come, instead of throwing the distal part or using the as a composite graft, is better to give a chance to reimplant it. So with this, we will again would like to take some of the questions which are being posed by the participants online. Of course, thank you, and they are thanking to us also. Thank you very much to that those participants. And now there is a question by Dr. Shami Purwar. The sutures. I don't know sutures for finger or suture for, but it was 416. 416 means for your fingers. So which suture do you use, sir? Give the mic to sir.
We usually use the 10O and 11O sutures.
Yes, 10O and 11O is the only answer. Otherwise, you will end up with more damage to the vessel than actually helping. Then nail bed graft. Nail bed graft is fixed with the nail plate on top, or was it?
It's always nail plate on.
Yes, because if you don't do that, the growing end will be in trouble. And as we all of know that the fingertip is the eye of the hand. A blind man can read the braille just by fingertips. So nail bed and the sensation at the tip, both are important. Otherwise, it's just like a block of tissue. So that's a good question, and the nail bed injury also should be taken care. With this, I think most of the questions have been taken up, and with this, I would like to thank the speaker of the day for the wonderful talks, both on the complex lower limb reconstruction as well as on the fingertip amputation. And with this, we have taken up all the questions, but still, in case there is a question, thank you to Dr. Jitendran and the JIPMA. Thank you, Dr. Amrika. So that also, anyhow, if you pose some questions, we don't mind taking any time, and you can always take the question to WhatsApp to Dr. Jitendran. He will be very happy to share his working experience. With this, now we will come, Kavita, start the. There is another question. One more question has come. Show. 1 minute. Yes. So what is the sequence? That's a very practical question. Sequence in micro is important. What do you do? As you have told, I think artery first, see the vein bleeding or not. That you will identify also for the zone 1. For zone 2?
Vein first, then.
Okay. So it depends upon the zone.
Supposing you are able to find the dorsal veins, you do the dorsal veins. External, first extend the tendon. Bone, extend the tendon, dorsal veins. Close the skin, come to the oral aspect, and do that. But if you are doing in zone 1, you do the nail bed first, then do the artery, then the.
Okay, I think that answers the question which was posed. And with this, we would like to take the next part of the session. That is the Thanksgiving session to Dr. Jitendra, the speaker of the day. And we would like to felicitate him. For this, I would like Dr. Friji and Dr. Mahapatra also to come and felicitate him. First by one citation, Dr. Friji. Dr. Friji. Dr. Mahapatra, you can also join. And also one gift from our side. Dr. Friji and Dr. Mahapatra, please take a photo. I hope this gift will be useful for you. Yes, functional gift, not the anatomical gift. So functional gifts are better than the anatomical gifts. Sure. So I hope it will be useful for you, sir. And now time has come to distribute the certificates to participants by our speakers and our faculty. So those who are physically available, please come. Dr. Jacob, Dr. Bharat, our resident, MCH residents, and other resident and sister. And Dr. Friji, please join. Dr. Jitendra, please come here. Others, those who are participating will be receiving as a e-certificate on their on their email, which they have informed. Dr. Jacob is also our MCH resident. Please come yourself and tell your name also, so that it will be introduction. Please tell your name and Dr. Anand. Other also can come. Please come, sister. They are the one who are helping in the micro cases, otherwise in the patient management, and they must know what we need them and what we need from them. Tell your name. No. Okay. Next, brother, come. Sister, you also come one by one. Madam is not coming. Madam, your faculty. Please come, madam. No, she's our faculty, and yeah, Dr. Anjali. Yeah. Sister, you please come after that. Tell your name. There are many more in our department who are now busy in the OT and the other part of the department. We will distribute. Thank you very much. Thank you very much. And now time has come to a vote of thanks. I request Dr. Mahapatra to deliver vote of thanks.
Thank you, Professor Dr. Chittadeya, sir, for this thing. We are really grateful to Dr. Jitendran for agreeing to come here and share his experience. And I'm very sure that it will be very helpful to all the residents who have been, all the participants who have been attending it online. And I would like to thank all our participants online and offline. We have members joining from Pondicherry Plastic Surgery Club, Tamil Nadu Plastic Surgery Association, South Zone of Plastic Surgery, East Zone of Plastic Surgery, as well as our Orissa Association of Plastic and Reconstructive Surgery Association. They've all come. And I thank all the members who have come here physically. Special thanks to Anjali Madam. She comes every time. We are really thankful to you for joining. Then I would like to thank our administration for permitting us to conduct this program and this telecasting. Professor Dr. Chitra is head of telemedicine. So he has telecasted it all over the country and outside the country also. We are really thankful to you. And we are thankful to our sponsors of today's program, Urgo, Mr. Ramasha, Mr. Ganesh, Mr. Muthukrishnan, and Mr. Janakiraman, who have taken the effort to conduct this program. And we are also thankful to our other members of the department who regularly help us in conducting this activity, as well as the members of the telemedicine team of Shikmar, Kavita, Ishak, for allowing us to conduct this program. With this, I come to my end of my vote of thanks, and we look forward to another program similar in future. Thank you very much.
Thank you, Dr. Mahapatra. Actually, Dr. Mahapatra only contacted you and called us, and then Dr. Friji immediately agreed. Yes, and Dr. Friji knows you very well, being you are in the Bangalore. So now I request all of you to rise for the national anthem. So with this, we conclude the program, and we will have a group photograph here. Those are physically present, but the telecast part now we are concluding. Thank you once again, all of you who have participated physically and online.